Okay. Treatment initiation. One of the things that is important to keep in mind when you're looking at multiple psychiatric issues is making a decision about where you start. You can't start everywhere. And as I've said, you've got kids with anxiety disorders, ADHD, and tic disorders. The first two are things that you're likely going to want to treat or could possibly treat, but you have to start somewhere. And there's a decision-making process that often helps. So, for example, one of the things I know about psychostimulant medications, like ADHD medications, the Ritalins and the Dextrins, is that they work really, really effectively for ADHD, but they also pretty predictably increase anxiety. They also pretty predictably, if you have a proneness, a predilection towards having repetitive phenomena like tics or stereotypies, at least when you're getting used to it, you see an increase in those behaviors. Now, one of the things that I pay attention to is the fact that you are trying a medication in a child. And most parents, myself included, would be quite anxious about putting a pill into my child's mouth that has a brain effect. And especially when you're relatively naive to this and you haven't gone through it, you do not want parents' first experiences to be the negative one, because then they're never going to come back. And so it's really important to pay attention to not only what you're trying to treat, but what you're trying not to happen. So this is a long-winded way of saying is sometimes it's almost counterintuitive. I'll see kids who have both anxiety and ADHD, and they're coming in because of the school who's saying that they can't focus, they're disruptive, and so forth, all the things that have to do with ADHD. And I say to the parents, we need to treat their anxiety. And they say, why? But he's not that anxious. Well, yeah, he's a little anxious or whatever. And I explain to them, says, we can try and treat the ADHD, but I've done this before, and I know what's going to happen. His anxiety is going to go through the roof. He's going to get really moody. He's going to have all sorts of other issues. He's going to ups and downs on it. Until we get this anxiety under control, we're not going to be able to treat his ADHD. That's probably the single biggest reason why stimulant medications fail in kids with autism, is because they haven't taken account of either tics or anxiety beforehand and taken that into consideration. So in some cases, this is not always, but in some cases, it actually is important to look at treating another disorder in order to get here. And so you treat the anxiety, and then you are able to go back and treat the ADHD without resulting in some of these negative things happening. Reactive pharmacology. It's not bad enough yet. I mean, that's the phrase I hear. It's not that bad yet, or we don't need to. Really, again, I think changing parents' attitudes, changing people's, educators' attitudes, everybody's attitudes around what medication is not it's not a bad thing in and of itself. It's how it's used that can be bad. And it's a tool for us. And let's not wait until things are in crisis to try and treat them. Why? A, because medications tend not to work very well then. And B, you're probably going to end up treating the wrong thing. You start probably all going to be treating them with an SGA, which is going to be this targeting this global sort of phenomenon. Oh, the other myth about medications and autism, I hear it go both ways, both of which are not true. One is that kids with autism are extraordinarily sensitive to medications and they just need homeopathic doses. And the other is that they are extraordinarily unsensitive to medications and you need to hit them with a sledgehammer. And neither is true. I haven't found that kids with autism, as opposed to any other kind of neurodevelopmental disorder, are any different. I think as a general rule, you need to just go really, really slowly, take your time, and if you do so, you rarely run into more problems with side effects. Let's talk a little bit about stimulants, because this is a medication that brings up a lot of feelings and concerns on part of families. It's also probably the most commonly used, or one of the most commonly used medications for children with autism. The history on stimulant medication has changed quite a bit. When I started in this field 17, 18 years ago, at that point, the general consensus was that if you had an autism spectrum disorder, a stimulant medication was contraindicated. You did not use stimulant medication because there were studies that indicated there was an increase in what's called stereotypy, the mannerisms, increased posture, and social withdrawal. And so you didn't use them. Now, since that time, there has been more studies and more research has gone back, both looking at the earlier studies, but also just doing new studies, and has found we are now discovering that stimulant medications for kids who have ADHD and autism can actually be quite effectively used. However, you have to pay attention to developmental level. that probably the main issue with the earlier studies was they were dealing with individuals who had profound IDs, who were functioning at a very low level, and in that population you're more likely to see more problems and less response. And we're going to come back to that idea of age in a moment. So the current research I've only mentioned a couple of studies here. There's more and more every day. Kids with ADHD and ASD do respond to stimulant medications, 50% decrease on the Conners, with actually a decrease in some of the stereotypic mannerisms, inappropriate speech. There is, however, some evidence of social withdrawal and irritability, especially on higher doses, or higher end dose, so 0.5 milligrams, so that's kind of higher, not really high, but on the upper end of things. And that probably reflects, in my view, the anxiety that's not being addressed in these kids. There's also evidence more recently of atomoxetine being effective with ASD and ADHD. Atomoxetine is Strattera, for people who don't know. So how do I approach ADHD? I approach it the way I would approach ADHD in any kid. Start with stimulant medications. And again, I want to go back to why stimulant medications. We've had stimulants around for half a century. And we've had at least 3 generations of kids who have been exposed to them, and we now have follow-up data on them. We know from this research that there is very little compelling evidence that there are any irreversible effects from stimulant use that is negative. Irreversible meaning that anything that doesn't happen while you're taking the medication. You may have an adverse reaction you don't like, but if you stop the medication, those things go away. It does not impact brain development, and we have lots of data, half a century of data on that. Anything that's been around for half a century and has been used that commonly, we would pick up the risks. I believe that stimulant medications are probably the safest medication we have in psychiatry, which most people would not think. Now, in general, when you look at the studies on ADHD, the general consensus is that one of the 2 stimulant family medications, 90% of kids will get treated if they have just ADHD, again, if that exists. In general, what I would say is that kids who have autism and ADHD, and I'm trying to treat their ADHD, my success rate isn't as high. It's probably closer to about 60%, 50 or 60%, so a little more than half. I'm able to actually find a medication that can address their ADHD. And the magnitude of the effect may not be as robust or as big. But having said that, even a smaller impact in kids with all these other issues might be more significant clinically and functionally for this kid. So even though it's a 50 or 60% success rate, that's still 50 or 60% of kids who respond. One of the other things is just to pay attention to the fact that there may be some variance in terms of how ADHD presents in different populations, particularly in terms of autism. For example, one of the things that lots of kids, not all kids, but lots of kids with autism have a tendency to, just in terms of their own cognitive and psychological development, is a tendency to excessively focus or have an over-selectivity of attention. So you show them, we have one of the things in the ADOS, we show them a picture and you get them to develop a narrative, and the kids with autism are just kind of pointing out all the little things that you've never ever seen. They just picked out and they're like, well, what's that thing there? And like, I've looked at this picture for 1,000 times, I've never seen that before. Like, oh yeah, you're right, there's a flag there. That overly focus. Now that's interesting because ADHD, I hear this all about ADHD as well, is that no, Johnny can't have ADHD, you should see him in front of his video game. Right? ADHD is more complex than just not being able to pay attention. It's modulating your attention appropriately to the demands. So that includes changing your attention set and shifting it. So when you're playing a video game and mom says, dinner's ready, okay, mom, I'll be right there. That's what happens, right? The other issue that comes up practically in terms of the use is the idea of the long-acting medications. I gave this talk, or a version of this talk, at CADRA 2 years ago. CADRA is the Canadian ADHD something network. But it's kind of like the Canadian version of CHAD, which is another acronym I can't remember the full name for. But CADRA's recommendations now for Canadian prescribers is first-line agent, the first thing you should start with in terms of treatment of ADHD is a long-acting stimulant medication. So do not start with a short-acting, start with bifenton, start with Concerta, start with Adderall, or whatever is what the recommendation is. Now, it is possible that that's a recommendation that works for neurotypicals, although I'm not really sure it does for them either. But I know for this population of kids, I see more kids for treatment of ADHD because the community doctor has followed this recommendation. And what I mean by that is that I'll see kids who get started on bifenton, they have all kinds of adverse reactions, they get switched to Concerta, more adverse reactions, they get switched to Adderall, more problems. Finally, the pediatrician says, you know what, you got to go see Dr. Dua. And they come into my office and I put them on old 50-year-old immediate release Ritalin, magic pill. And the problems diminish or almost disappear. So for some reason, and I think part of this has to do with age and development, is that the unique formulation of some of these sustained release medications is helpful and useful, but might not fit every kid. And so I always like to start with the pure stuff, the agent itself, find out if the medication works, and then you can fiddle around with the formulation, whether you want to give it once a day or twice per day. But I would say as a take-home message, if you have a young child with a neurodevelopmental disorder and you're trying to treat their ADHD, I would always start with a short-acting medication, immediate release Ritalin or immediate release Dexedrine. Immediate release Ritalin and Dexedrine before hours, 3.5, 4 hours, between 3.5, 5 hours, depending on metabolism.
So by the afternoon it's gone then?
Aha, so this is a good question. So the question was, what do you do about the afternoon? The medication only lasts 3.5, 4 hours of short acting. What do you do about the afternoon? Well, this is what you do in the afternoon. You give them another dose. Usually, that's what we used to do before we had long-acting medications, which can be a bit of a pain. Right? And you have to get, all the forms filled out and so forth. At the same time, I think most of these kids' lives are so scaffolded, just having that arranged is usually not too much of an issue. The other thing to keep in mind is that in younger kids, under the age of 7, 8, 9 years of age, and if we're looking at school as a largely the place we want to get the benefit, they don't do a lot of thinking stuff afternoon. Right? They're running around in the afternoon.
So that means the sleep thing will be pretty good too because it's gone by 2 o'clock, right?
Exactly. So it may be for a younger child, this is the developmental perspective, for a younger child, you actually only need 4 hours of coverage, right? And so for some of those younger kids, it might not make much of a difference. When they get to middle school and they get to high school and they have, late afternoon things and they have after-school activities and they have homework and so forth, that's when the longer acting thing tends to become much more relevant. This is the one thing we work so hard at making our kids more like other kids, right? But then we keep them apart by their behaviors. So, the kids are so different because they're jumping around all over the place, right? If you can make them a little bit more integrated and more settled, they might be able to be more like the other kids as well. So there isn't a hard and fast point. But it does give me an opportunity to talk about this slide, which was the developmental perspective. One of the things I've discovered only in the last few years is that ADHD is really developmental in the sense that you need to get past that 4 to 5 year old point in a developmental age before you can actually treat ADHD. As a result, with kids with intellectual disabilities, the time to start ADHD treatment may differ. So a typically developing kid, the kid on the green line, 4 to 5, you can generally with confidence treat ADHD and the medications seem to work most effectively. If you have a kid who has a mild ID, you kind of got to wait until they're like grade 1 or grade 2 before you're going to be able to, first of all, be more accurate about discriminating ADHD versus other things, but also, for whatever reason, for their brain to actually be able to utilize the support of the medication. What is really interesting, this is what I've discovered in the last few years, is the individuals with profound ID. Sometimes it's 18 or 19 or 20 when we start treating their ADHD. And it has functional impact at 18 or 19 or 20. And so even though if you're seeing an older individual with these developmental disabilities, it's important to kind of go back, drill back. Where are they developmentally? I know they were tried on stimulant medications when they were 6 years of age, but they're functioning at an 18-month level then. These are those old studies about autism that we were talking about. Wait it, try it again. And so I often will say, particularly if there's presence of some type of intellectual disability, however vague, is every few years, if you think the kid has ADHD, they don't respond, try again. It's a simple thing to do. You can re-expose them, and you might find that you have more success with it in a few years. So the short-acting stimulant in DJ is continued through grade 2, grade 3. At this point, there's more after-school stuff going on, so the pediatrician now switches him over to a sustained-release version of it to give him more coverage in the late afternoon. Again, this time when they reintroduce the long-acting agent, the tics briefly go up, but then they come back down. Really, the family's quite pleased with this overall, other than the fact that he is already a lean kid and he really has seen appetite suppression. So appetite suppression, probably the single most common side effect of stimulant medication. The younger you are, the more significant it is. I think it's just kind of adolescents like to eat a lot, but and it's predictive. I mean, it's going to happen, But at the same time, just like anything else, I think it needs to be weighed in the context of the benefits. Is that if there are clear benefits associated with this treatment and it has some adverse effects, are these outweighed by, do the negative effects outweigh the benefits? And are there other ways that we can ameliorate those things? So it's not uncommon for me to talk with families about kids who do really well on stimulant medication but have this appetite suppression, is looking at other ways to kind of bolster their intake, protein shakes and so forth. But the point of this is that you may have to accept that a medication isn't going to be without any side effects. Things go well for DJ through to grade 4. Academically, he's meeting expectations at this point. And his EA support has been shifted. Now it's being used more for his social interactions. Nevertheless, by grade 4, he's kind of marginalized from his peer group, and he's starting to want to avoid social events, school events. And in grade 5, he seems more moody. He's gone back to some of his older behaviors. So things that they hadn't seen in a while are starting to show up, like some of his flapping behaviors shows up. Or this hooting tic has shown up at one point during an exam. He seems to be more withdrawing from things, more on his tablet rather than interacting with people. So the parents take him back to the pediatrician, but this time they get to see a child psychiatrist. In the psychiatric assessment, now DJ is 11 years of age. It's learned that there's anxiety as part of this picture as well that hadn't really come to attention before. So like the other boy we saw, this is a DJ, has always had nighttime fears. He co-slept with a parent till he was 8. He's always been described as shy. The parents had always related this to the fact that he had autism, though. He would never do show and tell. Forget it. Sharing day was no way. If he ever do a presentation in front of the class, forget it. He would never do that. A couple of years ago, when we talked about kind of generalized anxiety, a couple of years ago, there was a trip that his mom took, and for the first time, he started getting really, really panicky about something happening to her on this business trip, which was really surprising. And then again, he went through one of these germaphobe phases about 6 months ago, got more particular about food. In the interview, DJ says that, he feels pretty uncomfortable in new situations, meeting new people. He says he worries a lot. When you ask him about what he worries about, he starts referencing things that are happening in the world. Right then, it happens to be earthquakes, and he's worried about, he's heard about what's going on in Nepal, and now he thinks it's going to happen here, and he's getting very nervous about this. And so the psychiatrist diagnoses anxiety disorder with features of social anxiety, generalized anxiety, and some obsessive-compulsive behaviors. The issue here, then, is managing these multiple comorbidities. We're dealing with not only one disorder, but one disorder that might impact another. And I think it's always important whenever you enter into ADHD treatment or anxiety treatment in a kid with autism spectrum disorder or neurodevelopmental disorder to be aware of the fact that there are likely to be other things that could also get twigged by this. So don't be surprised that there are other things and to, in fact, search for them. It would have been great if the pediatrician in this case, who is a made-up pediatrician, had actually gone back, beyond the ADHD inquiry and said, well, is there evidence of anxiety? So we knew this in anticipation, and DJ wouldn't have to wait 2 years for things to deteriorate before he got to this point. But now you guys are going to know this. So DJ gets started on an SSRI. So an SSRI medication are medications like Prozac, fluoxetine, sertraline, Luvox, fluvoxamine. There are a variety of medications. In general, they all work basically the same. There isn't really any evidence that any one of them works better than the other. And kind of like your son here, he gets started on it, and some of the repetitive behaviors are the first thing they notice improve. The flapping goes down, the hooting goes down. Why does that happen? This is not a medication for stereotypies. This is not a medication for tics. Why does that happen? Well, we know that what aggravates tics is anxiety and agitation. If you bring down anxiety, not infrequently, if a kid has a tic disorder, you're going to see a diminution in the number of tics that they have. Stereotypies are, in general, ways that kids use motor movement to self-regulate affect. So if they're understimulated, they'll flap. If they're overstimulated, they flap. And it's that dysregulation. And so anxiety can also trigger dysregulation, and you treat anxiety, and some of the dysregulation improves. So it's not unusual for the first thing to be noticed, even though you're treating anxiety, is for these behaviors to change, which is always great because that's what everybody notices. Not the kid, but that's what everybody else seems to notice. So they go down in 3-month appointment. He did you find out that he's actually much more comfortable. He's doing a presentation in front of the whole class, something that he would never done. He's getting more into his grade 6 class and school events. At school, he's reported to be more talkative, at times a little bit too much even. He can get a little silly, a little immature. And so the family puts him into a social skills development group. Now, this is relevant because I think one of the things that does happen, and I hear about it, is that kids who have had chronic lifelong anxiety, and you treat their anxiety, it's like a wet blanket has been lifted from them. And this wet blanket, or straitjacket if you want to call it, that has been encumbering them all their lives, you suddenly move it, and suddenly, whoa, there's color out there. But they don't have the skills because they've never had to try and go into the real world. So they're impulsive, they're silly, and you need to pay attention to the fact that, yes, you may see unmasking of more immature behaviors, and you need to help support and scaffold and train them for that, and anticipate that their social skills are going to be lower because of the anxiety. This is not just true for kids with autism and anxiety, but true for kids with anxiety in general. That if you treat a kid with social anxiety, not infrequently, if their anxiety gets better and they're talking in front of the class, they're also being a little sillier, more like kids.